and welcome. I'm Catherine Banwell, your host for today's program. Today, we're focusing on how to live and thrive with CLL. We're going to discuss CLL treatment goals and how you can play an active role in your care. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining us is Dr. Catherine Coombs. Dr. Coombs, welcome. Would you please introduce yourself?
Sure. So my name is Catherine Coombs. I am an assistant professor of medicine at the University of North Carolina. My main patient practice is CLL and SLL patients, which make up probably about 80% of the patients I see. I do see a couple other types of leukemia and precursor states as well.
All right. Thank you so much for taking the time out of your schedule to join us today. We appreciate it.
No problem. My pleasure.
Since this webinar is part of Penn's Thrive series, I thought we could start with getting your opinion on what you think it means to thrive with CLL.
I'd say the first thing that comes to mind when I hear thriving in CLL is my goal for all my patients, which is to live their lives and enjoy their lives and to not let CLL take over their lives in any way. But it's, of course, important to be knowledgeable and educated about how the disease can impact one's life. But I think there's a lot of education that can also go with that to help individuals continue to enjoy their lives and do most of the activities that they like within reason.
Yeah. This helps us guide us through the conversation. So thank you for that. Appropriate treatment, obviously, is part of thriving. Before we get into the specifics of CLL treatment approaches, how would you define treatment goals?
Well, I think the first thing to jump into prior to going into treatment goals is asking the question, is treatment even needed? So CLL, in contrast to pretty much most other cancers, is not one of the cancers that needs to be treated immediately. At least in 2022, there is no proven benefit to early treatment. That is being questioned now that we have drugs that are much better tolerated, and there are some really nice clinical trials asking that question again, is early treatment beneficial? But at least what we know now is that that is not the case. And so as it turns out, probably up to a third of patients with CLL never need treatment in their lifetime. And that means that the disease progresses along usually at a slow pace, and individuals just die from something else, any number of other potential causes of death. The other 2/3 plus do need treatment at some point in their lifetime. And so the goals of treatment kind of depend on the patient. So there's not a one size fits all approach, in my view. I think it depends on what is most important to the patient. So I'll give two kind of drastic examples just to show how goals can be different. So CLL often is a disease of older individuals. So the average age of diagnosis is usually around 70 or so. But many patients have the disease for a few years, if not longer, prior to needing therapy. So one example patient could be an 85-year-old individual who has had the disease for a decade and finally needs treatment. So the goals of that patient may be to control disease, but he or she may not be so worried about getting into a deep remission, and may be very totally willing to be on a drug indefinitely in order to control the disease, alleviate disease-related symptoms, but perhaps not get into a deep remission. The other patient, just to take it to another far extreme, so I work at a academic medical center. I see some, very young patients, which is not the norm in CLL, but it does happen. Say it's a 40-year-old patient, his or her goals may be very different. They may not like the idea of being on an oral therapy indefinitely or until progression. And so the goals for that patient may be different. They may say, gosh, I'd like to do something a bit more intense to be able to be off of therapy. So I think in the end, there's no one size fits all approach. It generally for my clinic comes down to a discussion with the patient talking about what their goals are. Is it more important to be off therapy for some period of time and they're willing to sacrifice a bit more intensive of a schedule, or are they more appealing to be on a regimen that they're on indefinitely, provided that it still provides disease control and alleviation of the disease-related symptoms?
Yeah. Well, that leads me to my next question, which is what is the patient's role in setting care goals?
I think they should have a huge role. I think it should be a shared decision between the patient and their cancer doctor. I think at least as of now, there's not one proven best therapy. We have a number of therapies that work extremely well, but they differ quite a bit with respect to the schedule, the possible side effect profile, and sometimes in the cost, depending upon the patient's insurance. And so, knowing that there's not a superior therapy, I think the best approach would be to discuss all of the therapies that are highly effective, and then compare and contrast what those therapies may look like for the patient, and then make a shared decision.
I have a follow-up question to what we were talking about a moment ago. What would you say to a patient who has a lot of anxiety about having to wait for treatment?
Well, I think the first thing I would say is that anxiety is normal. I'd say more often patients are anxious than not, because it's really hard to be told you have a leukemia and that we're not going to do anything about it.
Right.
I think that's really hard to hear. The way that I try to counsel people is that my role as the doctor is to do no harm. And so if you have a leukemia and there's no proven way to make you live longer by giving therapy early on, if you're in that early stage of CLL where you're asymptomatic, by offering therapy, all I could do is make you worse. So I could give you a new side effect, I could add a cost burden, and until I have data to prove that that's going to make your life longer, which we do not have yet, maybe that'll be different, 5-10 years from now, but we do not have that yet. I could only hurt you. And so that's not what I want to do. I want to have you live and thrive. And so, the better thing to do based on what we know now and what we know our therapies can and can't do is to do the watchful waiting. But the anxiety is normal. And so depending on how severe the anxiety is, I have had patients meet with, at least at UNC, we have something called the Cancer Center Support Program, which is a group of psychiatrists, psychologists, therapists that can help talk over what it means to have a cancer diagnosis and not necessarily need therapy. Right. And then I also provide education on the other health issues that can come up as part of being a CLL patient, even on that watchful waiting program. The thing that we talk about the most is the increased risk for infections, which in the era of the COVID pandemic are of a major concern. Luckily, we have a lot of ways to decrease the health risk for COVID, whether it's due to the administration of vaccines or monoclonal antibodies, which, I think we'll probably talk about more later. But, so there's a lot of ways that people can live with it. I do think the anxiety is normal, but at least in my own practice, I found that most of the time the anxiety lessens with time because it becomes part of who you are, but it doesn't have to be all of who you are. I think, a lot of people can live their lives largely the same as they did before, with, a bit of extra knowledge about things that can come up in the future, but may never come up at all.
Let's walk through the types of treatments that are used today to treat CLL.
So for the non-watch and wait category, that means we're now thinking about therapy. Most of the time that involves a targeted agent. We largely are using a lot less in the way of cytotoxic chemotherapy. Not to say there isn't a role for it, but I would say in my own practice, it's not something that I have been using in the past several years because it's highly toxic. It is effective, but it can lead to some long-term toxicities. And it's also not quite as effective as these new targeted agents. And so those fall into two major classes. The first class is a class of drugs called BTK inhibitors. That stands for Bruton's tyrosine kinase. And so that's an important target in the CLL cells specifically. So the CLL cells are a type of B cell. And so BTK is important for the signaling of both normal and cancerous B cells. And when we use drugs to block that protein, that impairs the CLL cells' ability to multiply. And then we ultimately are able to control the disease with prolonged administration of one of these drugs. There are two FDA-approved BTK inhibitors. The first FDA-approved agent is a drug called ibrutinib, and then the newer agent is called acalabrutinib. There's another drug that you may have heard of called zanubrutinib that is not technically yet FDA-approved for CLL, but it is occasionally used given that it's FDA-approved for other lymphomas, and it is within the National Cancer Center Network guidelines for CLL treatment. So the big benefit of these drugs is they work phenomenally well at controlling the CLL. I would say the major downside is that they do have to be taken indefinitely. And so, patients ask, am I going to be on it forever? Well, it depends on what you mean by forever. We generally keep patients on these drugs as long as, number one, they're tolerating them, so no bad side effects. And then number two, as long as the CLL is staying under control. And so for that 85-year-old patient that I gave as an example, forever maybe until, the rest of their life, because they can work for 6, 7, 8 plus years. So they're highly effective, and some patients may go on them and then, die from something else years down the road. For the younger patients or patients who progress faster, we would then put them on something else whenever the drug stopped working, provided that they didn't have a significant side effect to the drug class. Yeah. So that's the big first class. The second large subset of therapies is a drug called venetoclax, which we typically combine with an anti-CD20 drug. And so the one that we use for patients who are getting their first treatment is called obinutuzumab. So venetoclax is a BCL2 inhibitor that inhibits this pathway within CLL cells. It's not unique to CLL cells, but the CLL cells are particularly dependent upon it, called apoptosis. And so when they get exposed to this drug, the CLL cells just die. They can't continue living. They die off. And so venetoclax works really exquisitely well at killing off CLL cells, probably works better when it's paired with this drug, obinutuzumab, and that's how it was approved in the frontline setting, those two drugs together. The big risk of that therapy is essentially it's kind of a weird risk. So when the CLL cells die too quickly, that can cause some problems in the human body because one has to metabolize all the debris left over from these dead cancer cells. And so the medical term we use for that is tumor lysis syndrome. And that can actually be fatal if not done in a safe way. Fortunately, when we do it as per the recommendations by the manufacturer, we've not had any adverse severe problems from it, but it ends up being that the patient has to come in weekly, every 5 weeks, to do a slow ramp up of the drug to kind of slowly kill off the cancer cells so that the body isn't overwhelmed by the contents of these dead cancer cells. The big advantage of this regimen is that because it kills the CLL so well, people can get into very deep remissions. And so instead of being a therapy that people are on indefinitely, it's designed as a 1-year therapy when given as the first therapy. And so it's 1 year and then they're done. And so people after that are in remission. They're not on any treatment. And they may feel like they don't have CLL. Most of the time the CLL does come back. Again, it depends on does the patient die from something else, which, does happen, when people are older. But it appears that it keeps people in remission for several years. So the median, which is how long it takes for half of patients to have their disease come back. The median progression-free survival has not yet been reached for the trial that was done using this therapy. And so that's at least, 3-4 plus years that we've been able to follow people. So very attractive in that you're done and then you just wait for the disease to come back, but largely feel good in the interim.
Yeah. When is it time to treat? What factors do you look at?
So there's pretty well-established guidelines for when treatment is indicated. The International Workshop for CLL has these kind of published guidelines. So it's something you could Google. Off the top of my head, the main reasons that I do treatment, which are included in these guidelines, are number one, if the patient has low blood counts due to the CLL. So that could be anemia or low platelets. Two is if they have bulky lymph nodes. They actually define bulky as 10 centimeters, so that's pretty big. Or if the lymph nodes are being symptomatic in some way, they're bothering the patient. They don't have to be that big. Three is if the patient has bulky spleen enlargement, or if it's causing symptoms. So the spleen is next to the stomach. So say, some patients may not be able to eat a full meal. That's another reason we could do treatment. Another reason is if the CLL is causing constitutional symptoms. So sometimes these are black and white. So one is unintentional weight loss of 10% or more of the body weight. The one that's not always black and white is fatigue. So patients can have fatigue from the CLL, but I've found often fatigue can be due to other causes. And so, that's something I consider an important job of mine, is to make sure we don't jump into CLL treatment if, say, there's some other cause for the tiredness, such as, say the thyroid's off, or, there's a huge amount of stress due to some other factor outside of the CLL. And then some other constitutional symptoms are CLL can cause fever or drenching night sweats. Those two, it's important to make sure there's not a concurrent infection, because infections can also cause those symptoms. Yeah. The last indication is patients with CLL can develop autoimmune cytopenias. And so that's when the immune system attacks some component of the blood cells. Most commonly, that's an autoimmune anemia or autoimmune thrombocytopenia. That's the term for low platelets. Usually we can treat that with steroids or occasionally just a CD20 by itself, like rituximab, to kind of calm down the immune system. However, if those kind of immune-based therapies fail the patient, then we could consider treating the CLL to help fix that problem.
Okay. We received an audience question prior to the program. They asked, what does it mean to be refractory, and how is that different from relapsing?
I actually just had a conversation about this. I'm not sure that's formally defined. I have heard one definition suggested is, so I think everyone agrees refractory means that you did not respond to your last therapy. And so that's actually really bad. Most of our therapies work in almost everyone. And so refractory is a term that it's generally accepted means no response. So whatever therapy you're on, the CLL did not get better, it got worse, that's refractory. Another definition that I've heard based on this recent discussion is if you had a short remission duration, such as 6 months or shorter. So most of the therapies we use should work for quite a while, usually on the order of years. And so some people also consider refractory a short remission duration, 6 months or shorter. Relapse is probably the more common scenario. And so that's a patient who has had some type of therapy, but they had a decent response, but that response wore off kind of more on a normal pace. So again, not on the order of months, but usually on the order of years.
There's not necessarily a one-size-fits-all approach to treating CLL. So how do you decide which treatment is right for a patient?
So I always look at their underlying disease biology. So there's a couple really important tests that I send for all of my CLL patients by the time that they need therapy. So the first is to see what their underlying cytogenetics and molecular findings are. So there are certain good findings and then certain bad findings. One of the bad findings is having a deletion in the 17th chromosome in the short arm of that chromosome. The chromosomes are the big pieces of DNA within everyone's cells, and there's findings that are common in CLL. So a 17p deletion is a poor prognostic feature. And then there's a separate test where we can actually identify mutations in a gene called TP53, and these behave largely the same as a 17p deletion. So I always check for both. It's two different tests. Oftentimes patients have actually both of these findings, a 17p deletion and a TP53 mutation, but sometimes you can have the mutation without the deletion and vice versa. So that is one finding that's important when talking about different therapies. The other really important prognostic test is the IGHV mutation status. So this is another specialized sequencing test. It looks to see if the patient's heavy chain of their immunoglobulin protein has undergone something called somatic hypermutation or not. It's actually good to be mutated. What we know about people who are mutated is that they typically have better responses to most therapies, and their disease typically is one that grows slower. So I use those factors, and then I have a conversation with the patient. The two main treatment classes that I spoke about. So the BTK inhibitors, those work actually really well. And even the people with these really bad prognostic features. And so people with the 17p deletion, the TP53 mutation, they can have disease control for 6+ years on a BTK inhibitor, which is really good. And that was not the case a decade ago when we didn't have these drugs. Right. So that's something that's been hugely beneficial for our patients. The venetoclax obinutuzumab regimen, that still works when people have the 17p or TP53, but it probably doesn't work as well. And so I had mentioned the median time for disease to come back hadn't been reached yet. It had been reached for that poor risk subset. And so the expectation for people with that poor risk marker is that the median PFS progression-free survival. So again, when after someone starts therapy, when the disease then progresses, is 49 months. So, it kind of gives me a rough estimate of, gosh, these are your therapy options. And then based on your underlying biologic factors unique to your disease, this is what you can expect out of therapy A or therapy B. The mutated or unmutated IGHV, similarly, those BTK inhibitors work extremely well, even in people with the bad unmutated finding. So I think those are always an option. I think the other treatment is an option, but the people with that bad finding do have a shorter time until they progress of just under 5 years.
Mm-hmm. Dr. Coombs, why should patients feel confident in speaking up and being a partner in their care? Do you have any advice for helping them find their voice?
Oh, great question. I think a patient is their own best advocate. And, we as their physicians always try to advocate for them, but we often don't know what their wishes and desires are. And so I think through kind of speaking to what's important to you, that can help me know a little more about what path we should take, because there's not always, one right path. So I've talked about these two great treatment options we have. I had one patient who, loved fishing, and he just didn't want to, be in the infusion center. And that's the person who should go on the oral drug where he doesn't have to come to and from as often. And so if you kind of tell us about your goals and your desires, that helps us, also be your top advocate, because then we have a little bit more background on what's important to you. So yeah, I think that's my main thought. So we're here for you, but we need to know what you value the most. We don't always know that.
Right. When should a patient consider a second opinion or a consultation with a specialist?
I never discourage a second opinion, so I'm a CLL specialist, but I've had patients ask for a second opinion, and I'm always enthusiastic about it. If a patient feels that they need another set of eyes on their case, which, I've learned some things from some of my patients who have seen specialists, in different areas of the country, or, locally. We have Duke right down the street. Sometimes different providers just have different perspectives, or sometimes the patient, just needs to hear something again if it doesn't sound right to them. So I've had patients, for example, who are on watchful waiting, who really just had trouble believing I have leukemia and you're really telling me to do nothing. And, but then they hear it from someone else and it just helps it sink in. So I would say the answer is anytime you think you need another set of eyes on the case. But I would say especially, for people in the community, I do think there's a lot of value in seeing a CLL specialist, once, if it's something, that you're interested in and your insurance pays. I think the community docs have one of the hardest jobs, and I don't think I could do it. There are so many different cancers that they have to know about. I think if anything, I have the easy job. I have one tiny slice of the pie that I know a ton about. And so not to say that they don't do great jobs. I'm actually phenomenally impressed with most of the community. However, they have so much to know. Often you can, maybe get a little bit more of a unique kind of view on CLL from seeing a CLL expert, if that's in your interest, but certainly not mandatory, especially if your goal is to stay away from doctors. Yeah.
COVID is, of course, another factor that impacts a patient's ability to fully thrive with CLL in today's world. Many CLL patients are concerned about the effectiveness of the COVID vaccines and their ability to make enough antibodies to fight the virus. So, what do we know about how effective the COVID vaccines are for people with CLL?
Yeah, the COVID vaccines, we were fortunate in being able to build on some earlier research. So even prior to being able to look at the data for COVID vaccines, there have been studies looking at vaccines in general in CLL. And so that's actually been a long-term established issue, which is that based on earlier studies, we knew most vaccines were not as efficacious in individuals with CLL compared to people without. And that's due to this underlying immune deficiency. So since then, they've done studies looking at COVID specifically, and we have found lower rates of production of antibodies in individuals with CLL compared to regular, non-CLL controls. There have been a few different studies looking at this. I think the things that have been seen universally is that the CLL patients that are the most severely affected are those that are actively on therapy or have had recent anti-CD20. And so the CD20 drugs really wipe out the ability to make antibodies, probably for a year, if not up to 2 years. The other drug class that can really hamper the ability to make antibodies are these BTK inhibitors. And then venetoclax, to some extent, it's often paired with the CD20, so it's hard to tease out the effect, but it likely hampers the ability to make antibodies as well, but just not as much as the CD20, which it's often, given concurrently with. CLL patients who have never had therapy can make antibodies. They can make a decent amount of antibodies, but still quite a bit less than age-matched control. So, someone also your age without CLL. So that was a lot of data based on the original 2 vaccine series. The Leukemia Lymphoma Society did a study that I actually referred a lot of my patients to, where they collected samples, looked at antibody levels, and they found that giving the booster did seroconvert a good amount of patients who were negative that then became positive for antibodies. And so, that's one of the reasons I really encouraged the booster. And so this is now speaking about the 3rd shot. So now there's this whole separate discussion about doing a 4th shot, which I think the data is a little too early to say, it's like definitely helpful, but I think it's certainly unlikely harmful. But yeah, so the vaccines, they don't quite work as well, but I feel very strongly they're not harmful. Not to say any shot can't cause some issue occasionally, but I think that's very, very rare. And so I always encourage my patients to get the vaccine, but I separately say, gosh, I wouldn't use this as an end all, cure because it may not work at its 100% efficacy level due to the underlying CLL and worse when you're on treatment.
We had another audience member send in a related question. I've heard there is a treatment to help boost COVID antibodies. What is it and how can I get access to it?
Yeah, I was going to bring that up actually, and I figured maybe there was another question coming. So I'm hugely enthusiastic about the drug that this person is speaking about. It's called Evusheld, EVUSHELD. It got this emergency use authorization designation in December of 2021, so it's pretty new. And the idea behind this drug is that, gosh, we know not everyone is going to mount an effective immune response to vaccines, based on their own immune system and ability to make good levels of antibodies. And so it's two antibodies that were manufactured, as this drug. So it's a drug that's actually two different antibodies. It ends up being in two different vials. So you get two shots, and it provides really remarkable protection against COVID. They're long-acting antibodies, and so they last for 6 months. And the publication from the study that led to this being released showed an approximately 80% reduction in COVID for the people who got the shot as opposed to the people who got the placebo.
So it sounds like patients could ask their doctors about where they might be able to access this.
Yeah, I think the best person to ask would be your CLL doctor, because the drug, unless things have changed recently, it's largely being focused for immunosuppressed individuals. And so I think primary care doctors may not necessarily know a lot about it, but most oncologists are the ones who should have access to it. So I would say ask your CLL doctor. And, if you're at a smaller site that doesn't have it, they may know in your own geographic region, where it can be gotten.
As we close out this conversation, Dr. Coombs, I wanted to hear why you feel patients should be hopeful about the potential to thrive with CLL.
I think there's just so many reasons to be hopeful. CLL, I'd say more than, obviously it's the cancer I'm focused on, but I think more than almost any other cancer has had advances that have really changed the lives of our patients in the past decade. And that's only going to get better. So we have therapies that work phenomenally well and can get you into remission, get the CLL under control, and let you just live your life as you wish. And, almost as though the CLL is not there, though it is in the background, and, your doctor can counsel you on, special precautions needed. But the drugs we have are phenomenal, but we only use them when we need them. So again, we don't want to give you something you don't need, but when you need it, the options we have are really phenomenal, and they work well. They have some side effects, but I'd say they're much better than the side effects of kind of the older fashioned drugs that we used to use, a decade plus ago. So the disease is there. We have better ways to control it. And I think there's plenty of reasons to just live your life, enjoy your life, thrive. And, we'll take care of the CLL with all these tools in our toolbox.
Right.
We need to.
Dr. Coombs, thank you so much for joining us today.
It's been my pleasure. Thank you.
And thank you to all of our partners. To learn more about CLL and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for joining us.